to the first ever Australian Sickle Cell Advocacy Conference running today and tomorrow. So we will be tackling genetic counseling in hemoglobinopathies with Miranda Lewit-Mendes, who is an associate genetic counselor at Monash Genetics. So I believe that's Monash Hospital.
Yeah.
But welcome, Miranda.
Thank you. So thank you for that introduction. So hi, everyone. My name is Miranda Lewit-Mendes. Now, before I begin, I would just like to acknowledge the traditional custodians of the land on which we meet today. So for me, this is the Wurundjeri people of the Kulin Nation. I pay my respects to their elders, past and present. So thank you again to the organisers for inviting me to speak tonight. As mentioned, I'm a genetic counsellor working at Monash Genetics at Monash Medical Centre, which is in Melbourne. And I specialise in providing genetic counselling for families who are impacted by hemoglobinopathies, including sickle cell disease. And tonight I'll be presenting on genetic counselling with a focus on sickle cell disease. So I'll explain a little bit about what my role involves and the genetic services available to families who do have sickle cell disease. So I'll sort of go through some of the information that we provide during genetic counselling, focusing on the genetics and the inheritance of sickle cell disease. So hemoglobinopathies as a whole are not rare at all. And as this table shows, in some populations around the world, up to 1 in 4 people might be a carrier for sickle cell disease. So this is likely because it is thought to give a survival advantage against malaria if you are a carrier. So places near the equator where malaria is more common are more likely to have a higher frequency of sickle cell disease. And as Dr. Barbaro mentioned earlier tonight, migration from these areas around the world where sickle cell disease is more common is increasing the prevalence in Australia. So Melbourne particularly is a very multicultural place. So we are seeing more and more people who are carriers for sickle cell disease or have the genetic condition themselves, and who are coming to genetic counselling at Monash in relation to this. So what is genetic counselling? So it's the process of helping people understand and adapt to the medical, psychological and familial implications of genetic contributions to disease. So to put it simply, genetic counsellors provide information and support to people who have a genetic condition in their family, such as sickle cell disease. So this involves a lot of talking and listening to individuals, couples and families who might have sickle cell disease themselves, or a family member of theirs might have it. So genetic counselling involves interpreting family and medical histories to assess the chance of a genetic condition occurring. So for example, if a person has sickle cell disease, then we may assess the chance of this happening in their future children. Genetic counselling involves education, so where we educate people about the inheritance, so how conditions are passed on through the generations. We provide information about testing options and also management. And genetic counselling also involves counselling, as the name indicates. So the counselling provided is a bit different to sort of what you'd usually think of as counselling or therapy, which is usually more of an ongoing process. Whereas genetic counsellors, we might only see a person or a couple maybe once or twice, depending on their needs. The type of counselling is more focused on supporting people to make informed decisions about genetic testing and helping them cope and adapt to those results. So this might involve one appointment before having genetic testing and 1 or 2 appointments afterwards, but it depends on the person's needs. And we also do a lot of work behind the scenes relating to organising genetic testing if that's something a person wants to do, and ensuring people impacted by genetic conditions such as sickle cell disease can access adequate support. So just to give you an idea of what a genetic counselling session may actually involve, these are sort of the main aspects. So we take a detailed family and personal history to better understand the person's experience with the condition they're coming to talk to us about, and also to provide a risk assessment of the chance of that condition occurring in them or their child. So a discussion about the condition, so sickle cell disease, in this case, if they don't have the condition themselves. We provide an explanation about genes, chromosomes, and inheritance. So we talk about the genetic basis and the inheritance of sickle cell disease. If genetic testing is relevant, we might talk about the different options for that. So carrier testing, if they're wanting to know if they're a carrier or their partner is a carrier. Prenatal testing, so that's finding out if a pregnancy has sickle cell disease, or talking about the option of IVF with genetic testing as well, if they might be considering having a child and want to avoid passing on sickle cell disease. After providing, I guess, the information aspect, we do a lot of support helping people make informed decisions. So exploring the possible outcomes of genetic testing and what the impact might be on them and their family. And then if they decide to go ahead with testing, we would arrange that for them, and then discuss the results with them and provide follow-up support after giving those results. So the genetic counselling concept changes a lot depending on the person's needs. And we always aim to be sort of patient-centred. So, we are guided by what they need. So tonight's presentation will sort of go through some of the information that we would usually discuss in a genetic counselling consult. So just to start, as you probably all know, hemoglobinopathies are genetic conditions that affect hemoglobin, and they include sickle cell disease and the thalassemias. So hemoglobin transports oxygen around the body in our red blood cells so we can get the energy from food that we eat. Adult hemoglobin is made up of iron plus 2 alpha globin chains and 2 beta globin chains. So this information is helpful to assist people to understand sort of the genetics and what we're talking about when we talk about sickle cell disease. So reduced or abnormal production of those globin chains leads to hemoglobinopathies. So the type of hemoglobinopathy that you get depends on whether the alpha or the beta chains are affected and whether or not they're being produced or an abnormal version is being produced. So in sickle cell disease, the abnormal beta globin chains are produced, which leads to something called hemoglobin S being produced instead of the normal adult hemoglobin. And as I'm sure you all know, hemoglobin S has an abnormal structure. And this leads to all the features of sickle cell disease that I'm sure you're all very familiar with. Sometimes couples coming for genetic counselling might not have anyone in their family or themselves with sickle cell disease. So usually we would do genetic counselling along with a haematologist specialised in that condition who can provide a lot of details about the medical implications of the condition and the treatment and management. If they don't have that experience from someone in their family having the condition. So why is hemoglobin S produced? So it all comes back to our genes. So this picture is often something that we would show people to explain why sickle cell disease occurs. So our bodies are made up of billions of cells, and inside each of these cells is a copy of all of our chromosomes. And these are the structures made up of DNA that store all of our genes. We've got 2 copies of each chromosome, one from each parent of each, which means we've got 2 copies of most of our genes. So these genes contain the instructions for our body to grow and function, including genes that contain the instructions to produce the alpha and the beta globin chains, which make up hemoglobin. So hemoglobinopathies occur when a person has changes in either the alpha or the beta globin genes, which contain those instructions for making the globin chains. you can think of a change as a bit like a spelling mistake in the instruction. So these changes or spelling mistakes mean that the globin chains are either not produced, which leads to thalassemia, or they're produced in a different way, which is what happens in sickle cell disease. So as I mentioned, each person has 2 of the beta globin genes because we get 1 from each of our parents. And a specific change or spelling mistake in that beta globin gene leads to the production of beta globin, which is different to the standard. So it leads to production of hemoglobin S instead of normal adult hemoglobin. Carriers for sickle cell disease have 1 normal copy of the beta globin gene and 1 copy of the beta globin gene with the hemoglobin S or sickle cell gene change. Now, usually this sickle cell gene change is inherited from one of their parents. It's often passed on through the generations. Because carriers don't usually have any symptoms, often people will not know that they're a carrier until they have testing. Individuals who have sickle cell disease have that sickle cell gene change in both copies of their beta globin genes. So they've got no standard copies of the beta globin genes left, and only that hemoglobin S is produced. So sickle cell disease can also be caused by one parent carrying hemoglobin S or the sickle cell gene change and the other parent carrying a different type of change in the beta globin gene, which Dr. Barbaro touched on earlier as well. So if one parent carries beta thalassemia and the other parent carries sickle cell disease, then that can also lead to a slightly different but still significant version of sickle cell disease. There's a few other different genetic variants that you can have that will also lead to a sort of similar condition. In some cases, it can be a little bit milder. So a lot of my work involves talking to couples about carrier screening results. So in Victoria, all couples are meant to be offered screening for hemoglobinopathies if they're planning a pregnancy or early in pregnancy. This is because it is really common and carriers are usually asymptomatic. So people often won't know until they have this testing. And it's usually arranged by their GP or maternity team or sometimes by me. It's just a standard blood test, and both parents need to have testing to know whether there is a chance of having a child with sickle cell disease, because it's the combination of their genes that determines that risk for their children. Something to mention is that there are options for what we call reproductive carrier screening. So these are private tests that screen for multiple genetic conditions, including sickle cell disease, but a lot of other ones as well. And that's something that's becoming sort of more available for couples planning a pregnancy or early in pregnancy. So as you probably all know, sickle cell disease is inherited in what we call an autosomal recessive manner. So this is where either both parents have to be carriers of sickle cell disease or have the condition themselves to have a child with the condition. If only one parent has sickle cell disease or is a carrier and the other parent is not found to be a carrier, then it's an extremely low chance of having a child with sickle cell disease. As I mentioned, we've all got the 2 copies of that beta globin gene, and every time a child is conceived, 1 copy is passed on from each parent, and it's a 50-50 chance of which copy of that gene you pass on. So if both parents are carriers for sickle cell disease, there's a 25% chance for every child that they have to have sickle cell disease. It's the same risk for every single pregnancy. So just because you've had one child previously that does or doesn't have the condition, that doesn't predict at all what the next child will have or not have. If one parent has sickle cell disease themselves and their partner is a carrier, then there's a 50% chance of having a child with sickle cell disease, because the parent with sickle cell disease only has those abnormal beta globin genes to pass on. They don't have any normal copies of the gene. So it's completely determined by what their partner passes on as to whether their child will get sickle cell disease or not. So there are different options for couples at risk of having a baby with sickle cell disease who are planning a pregnancy or pregnant, which has already been discussed quite a bit tonight in the previous talks. So there's the option to have a natural conception and not do any testing at all, although it's not really recommended not to have any testing because of the treatments that you can do if you know that a person has sickle cell disease. Some parents will choose to wait until birth to test their baby. So that can be a good option to do that. The other option during pregnancy is to have prenatal diagnosis, so the CVS or amniocentesis, which can tell you while you're still pregnant whether or not that baby will have sickle cell disease. If you're coming pre-pregnancy, we would talk about the option to use IVF technology to fall pregnant, and the option for pre-implantation genetic testing, or using a donor egg or sperm or embryo if the couple are wanting to avoid passing on sickle cell disease. And some people might choose to not have any children or adopt is another option if they are really concerned about the chance of having a child with a genetic condition. So the CVS and amniocentesis are invasive tests. So it involves a needle being inserted through the top of the pregnant person's tummy and into either the placenta or the fluid around the baby. So the needle is not touching the baby and is guided by an ultrasound at all times to ensure it goes into the right place. The sample of placenta or fluid is then sent to a genetic testing lab who are able to determine whether that baby has inherited the sickle cell gene changes or not, and therefore whether they'll be affected by the condition or not. It is obviously an invasive test that does have a small risk of miscarriage associated with it. The risk is usually quoted at being between 1 in 500 to 1 in 1,000, although the latest meta-analysis indicates it's potentially even a smaller risk than that. At Monash Hospital, a CVS can be done between 12 to 14 weeks gestation, and results usually take about 2 weeks from the CVS. So people can sometimes get a result back by about 14 weeks. And then if they're a bit later in pregnancy, they have the option to have an amniocentesis from around 16 weeks. And results from genetic testing for that take a bit longer, so 3 to 4 weeks. So it's preferable to do the CVS if you know ahead of time, but that's not always the case. So the amniocentesis is an option for people who decide they want prenatal testing later on in pregnancy. In Victoria, this is currently the only way to determine if a baby will have sickle cell disease or not before birth. However, it's possible in the future that there might be non-invasive testing options available. So fingers crossed that technology becomes an option soon. So the purpose of prenatal testing through a CVS or amniocentesis is to determine if the baby will have sickle cell disease or not before birth. And people choose to have this test for different reasons. So some couples might choose to have prenatal testing because they want to plan for the birth of an affected child, or because they can't cope with the uncertainty of not knowing and they need to have that certainty while they are pregnant. Whereas other people might choose to have prenatal testing for the purpose of decision making. So they do have the option to either continue or have a termination of pregnancy if the baby is found to be affected. It's a very personal choice for each couple whether or not they want to have testing and what they would do with the results. There's no judgment about what they choose to do, and there's no right or wrong answer. We support couples to make the decision that's right for them. We assist in their decision making by providing all the relevant information and then supporting them through the choice that they make. For couples who aren't considering having a termination of pregnancy, they might choose to test after birth, given the risk of miscarriage with those invasive procedures. However, some couples might still choose to have prenatal testing, even if they're not considering a termination, because of that need to know or wanting to plan. And we absolutely would support that decision as well. It's up to them. So a little bit about IVF with pre-implantation genetic testing. So this is an option that we talk to couples about who are at risk of having a child with sickle cell disease or another genetic condition. So this involves going through the IVF process to fall pregnant. So I guess a bit of a downside is that people might not otherwise need to go through IVF for fertility reasons, but you do have to use this technology to do the pre-implantation genetic testing. So embryos are created outside the body through IVF, and then a genetic test is performed on the embryos in the lab to identify which embryos are likely to have the genetic condition or not. And then only an embryo without sickle cell disease would be implanted into the woman's uterus. So a big advantage of this is that you can avoid passing on sickle cell disease if that's something that the couple wants, and you can obviously avoid having to go through the process of falling pregnant naturally and terminating a pregnancy, which isn't an option for some people. The disadvantages are that there can be a significant emotional, financial, and physical burden. Not all IVF cycles will lead to a successful pregnancy. So sometimes people might have to do many rounds of IVF before falling pregnant, or, they might not have many embryos that aren't affected with the condition. So they can be some disadvantages of this process. In terms of the financial burden, it can be quite significant. There isn't Medicare funding or a lot of Medicare funding currently, but it is something that might be available in the future for couples at risk of having a child with a genetic condition. So as you can probably understand from this presentation, one of the main roles of us as genetic counsellors is to facilitate informed decision-making. So this involves providing all relevant information in an unbiased manner, discussing the advantages and disadvantages of different testing options, ensuring our patient is making a decision if they do decide to have testing or not, free of influence, and that it's an autonomous decision for that person or couple. We provide people with the time and space to deliberate about what they want to do, and we support whatever decision they make and support them through the whole process. So these are just my contact details. If anyone does have any questions or wants to find out more or seek genetic counselling.
Okay, thank you, Miranda, for a great presentation. That was really informative, especially off the back of the numerous sessions that we've had around screening this evening. So that was really great. I will just check if we have any questions from any of our participants. Okay, so at the moment I see no questions, although I do have just maybe one, and I'm trying to see how I'm going to frame it. I I would just like to understand, how do you measure, for example, the effectiveness of the programs that you run, in terms, when you are, providing these informed decisions to people? How do you measure that, this program is really working, especially further down the line in helping people to make decisions that obviously have a bit less difficult impact on their lives, because having a child with sickle cell disease is obviously, it can be challenging at times. Yes, it is manageable, but how do you measure that? I'm just interested to find out.
Yeah, good question. I guess there is a bit of research into sort of the impact of genetic counselling and things like decisional regret. So whether people are more likely to regret decisions about testing or, continuing or terminating a pregnancy when they've had genetic counselling or not. I guess on a personal level, we do a lot of reflection and supervision, sort of looking at appointments we've done where we might have felt like, they haven't gone as well, or we haven't been able to support that patient effectively, and thinking of, what we might have been able to do differently. I guess on a sort of more clinic scale, we don't really have any official recording in place, but there definitely is sort of research looking into how genetic counselling can impact people. It is something that's a little bit difficult to measure.
Without trading into eugenics or anything like that, yes, I definitely understand. That's why I was trying to frame my question. And the other one, so for us, we are a patient support organization. So I'm just also trying to understand, how can we, and with the help of professionals like you guys, help to bridge that gap, where we provide more awareness? Because from what I see, it's really a lot about informed decision making. How do we help to narrow that gap?
Yeah, so I guess it's just about making sure that people are aware that genetic counselling is available, and also importantly, encouraging people, I guess, to access genetic counselling regardless of whether or not they do want to have sort of, any testing. So I think some people might think that genetic counselling is only relevant if they are going to, test a pregnancy, or if they want to avoid passing on a genetic condition. But it's definitely not only for those people. We see a lot of people who just want the information and don't, want to make any changes based on that information. So I guess, if as a support organisation, you sort of talk about those aspects, and then hopefully as a genetic counsellor seeing patients with sickle cell disease, or, who might be having a child in the future with that condition, I can then link them in with you as well to hopefully give them that support as they need.
Absolutely. Thank you very much, Miranda. This was really fantastic. We thank you for the information, and we'll definitely make sure that it is widely available to our supporters and all our members.